just showcasing the work of one researcher, Dr. Tenny Lewis, was a professor at Yale University. Every line on this study reflects a different study she did using the same measure of discrimination, these little things. And people who report higher levels of everyday discrimination have higher levels of coronary artery calcification. That's a rapid development of heart disease, a subclinical development of heart disease. They have higher levels of inflammation as measured by C-reactive protein. They have higher levels of blood pressure. Women who were pregnant report everyday discrimination are more likely to give birth to babies who are low birth weight. Elderly persons who report everyday discrimination followed over 5 years have more rapid declines in cognitive function. Persons who report, community dwellers who report everyday discrimination sleep more poorly at night. A study of the elderly finds that everyday discrimination literally is killing them, elevated risk of mortality over a 10-year follow-up period. And a study of black and white women, high levels of everyday discrimination is linked to visceral fat. Visceral fat is the bad kind of abdominal fat. Abdominal fat is of two kinds: subcutaneous fat, just under the skin, and the visceral fat, the deep fat in between your body organs that predicts higher risk of cardiovascular disease and diabetes and so on. Everyday discrimination unrelated to subcutaneous fat, but linked to the bad kind of visceral fat. What's happening in the US is also happening in the UK. BME folks experience discrimination not just in the NHS, but throughout society. Here is a recent paper from last year, colleagues at the University of Manchester, using the National Longitudinal Study of Infants called the Millennium Cohort Study in the UK, and they assessed maternal discrimination. These were the measures they used, and this is what they found. Among ethnic minority mothers in the prior 12 months, 23% reported racial insults, 16% reported disrespectful treatment from a shopkeeper or salesperson, similar items to the everyday discrimination scale. 19% reported they were treated bad unfairly, 23% report family members were treated unfairly, 12% report insults or attacks due to their race or color. What is the impact of this on the mother's health and of the health of the little infant that they are raising in British society? What the researchers found, that reports of racial discrimination by these mothers in 2006 predicted the mother's mental health in 2 years later. So there was a longitudinal relationship between the experiences the mother had and her mental health, and it predicted the child's socio-emotional development in 2012. So there's a direct link between what's happening to the mother, racial insults in the mother having these consequences. Racial insults in the mother, disrespect from shop staff directly predict a child's emotional development in 2012. And again, racial discrimination by the mother was associated with harsher parenting practices, which also predicted child emotional development. So they're showing them multiple pathways where the mother's experience literally affects her health and her functioning and the child's functioning down the road. Let me show you an even more disturbing study just published. This is from the UK longitudinal study, just published this year. In the last 12 months, had 4 items capturing the extent to which BME folks in the UK felt unsafe, avoided going or being in certain locations because of their race, were insulted, called names, threatened or shouted at, or had been physically attacked. About 40% of Indians, Pakistanis, Bangladeshis, and Black Africans report having had one of those types of experiences. They were asked the question twice, 2 years apart. And within those 2 time points, about 40% of these groups reported, and about 25%, 1 in 4 of Black Caribbean reported those experiences. How do those experiences matter for their health? They looked at the reports of discrimination at 2 points in time and looking at their health 4 years later. These are measures of mental health 4 years later. And what they are finding, compared to persons who report no discrimination, persons who report discrimination, one event of discrimination, either one time or at both times, their health is 1.9 times, this is a 12-item measure of mental health, 1.9 times lower. If they reported 2 or more events at one point, their health is 3 points lower, mental health is 3 points lower. If they pointed at least 2 events at one time, and one event at the other time, so they reported discrimination at both times, and once it was at least 2 events, their mental health was 5.6 points lower. And if they reported 2.3, more than 2 events at both time points, their mental health was 8.3 points lower. Basically, what they're showing is the more discrimination these BME folks in the UK experience, this is national data from the UK longitudinal study, the worse is their mental health. And there's a dose-response relationship between the more you have and what happens. And as you well know, there are challenges for BME staff that we are all very well aware of: the harassment and victimization at work, the perceived unfairness, the lack of consistency and opportunities for advancement, very limited representation in leadership positions. This is all work that has been well documented in the UK. And you've seen the RES data, but I just wanted to emphasize it and put it in a way that you could dramatically see it. Harassment, bullying, or abuse of staff from patients, relatives, or the public in the last 12 months. You can see in some trusts that BME staff are reporting this at much higher levels than whites, but not in all trusts. But this is discrimination and harassment from patients, relatives, or the public. If we look at discrimination and harassment from staff in the last 12 months, you can see the trusts are higher. This is the percent of trusts where more BME staff are reporting these compared to white staff. If we look at indicator number 7, opportunities for career progression or promotion for BME staff, you can see that the percent of trusts where fewer BME staff believe that there are equal opportunities for career progression or promotion, 86% in acute trusts, 100% in community provider trusts, 80% in mental health and learning disability trusts, 50-50 in ambulance trusts. Indicator number 8, discrimination at work from a manager, team leader, other colleagues compared to white staff. Again, you can see the overwhelming majority, percent of trust is over 80%, except for mental health trust where it's 73%, where more BME staff experience discrimination at work from a manager, team leader, or colleague compared to white staff. So kind of very disturbing data that we've been talking about all day. The limitations of the data should be highlighted, that there isn't full coverage, has been mentioned, of all the staff, one, and also the fact that BME staff have a lower participation rate, so that maybe even the data we have maybe underestimates given the lower participation. What can we do about these, and how can we move forward with diversity, and how can we ensure we are successful in what we do? I think it's important. People use diversity to mean a lot of different things, and I emphasize the importance of thinking about what I call critical diversity. It's the equal inclusion of all people from all backgrounds. Special attention to those who have been excluded in the past, attention to parity at every level. It's the kind of diversity we need. We also need to be aware that in our society today, many people use diversity as a ploy to forestall social progress. Diversity is often decoupled from concrete and purposeful initiatives and incentives to effectively address racial inequalities. So we need to ensure that when we use diversity, we are using it in a way where we are trying to accomplish change. Why should we care about diversity? I'm not going to spend time on this because it's been made already in this session today, that higher levels of diversity are associated in good scientific studies with greater creativity and innovation. So if we want to develop, produce the highest quality outcomes, we want greater diversity, so there's greater creativity and innovation. It's also been mentioned there are large economic benefits to diversity. That's been true in the healthcare world as well as in the world, more generally, the business world. However, I want to talk about some challenges that we need to think about. It's not enough to open the doors of opportunity. We need to think of how we address pipeline and recruitment issues, how we prepare. We want more BME staff as the senior leaders. What are we doing to groom and train them? How are we providing them to be ready when the door of opportunity opens? And to illustrate the importance of that, I'm going to use US data and ask you a simple question. Affirmative action were policies implemented in the 1960s in the United States to address the underrepresentation of women and minorities. How well did these policies work for women? Remarkably well. Here is an example of female graduation trends from US medical schools. In 1965, 6.9% of the graduates of US medical schools were women. In 2010, 48.3% were women. Women are half of enrollees in medical schools in the United States today. Affirmative action has worked remarkably well for women. How has it worked for BME folk in the US? You could see blacks were 3% of medical school graduates in 1950 and 1960, and affirmative action was implemented, and blacks are 6.7% of medical school graduates in 2010. Hispanics are also about 6.8%. Blacks and Hispanics are about 25% of the United States population. They're about 12% of the medical school graduates, and you don't see dramatic changes over time for these groups. Why have women been so much more successful than BME folks in the US? Because women were more prepared to walk through the doors when the doors were open. It's not enough to open the doors. We need to think of what we are going to do to ensure that individuals can walk through the doors and are prepared and trained and groomed so that they can take advantage of the opportunity. So in the US today, in 2014, there were 27 fewer black males in the first year of medical school than there were in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. And in 2012, 3.8% of all practicing physicians in the US were black. So we went from 2.9% to 3.8%. I'm just trying to make the point, this is not a 2-year project. It's going to take a lot of effort and energy and greater creativity than we have had in the US to solve the problem. It's not enough to open the gates of opportunity. Everyone needs to be able to walk through the gates. It also means that making progress on increasing diversity and inclusion requires a long-term commitment. This is a journey. This is the start of a long-term journey. It's going to take dedicated effort. What do we know about doing diversity right? What lessons you can learn? Well, we know that just diversity training alone does not lead to increased representation. Mentoring and networking, as important as that is, only show modest effects. You need initiatives that have embedded accountability, mandates, and authority. Those are the initiatives that work successfully over time. This is a study of US corporations between 1971 and 2002 that shows what works to be successful in diversity. One of the things we need to do is to completely change how we think about diversity. This is an example of a study done in the US Army. The US Army had well documented a problem, although there are a lot of blacks who were qualified for advancement. When they would go up for promotion, they were not getting the promotion. And so the Army altered its promotion procedures. First, it instructed promotion boards to be race and gender conscious. It reminded them that all groups were central to the mission of the Army. It reminded them to assume that black and female candidates up for promotion were as qualified. And then it did something else. If a promotion board was turning down a candidate who had been brought up to them, they couldn't just turn down the candidate. They had to document in writing the rationale and the reasons why this person was not receiving it. Simply having them document why persons were not receiving the promotion that they were nominated for eliminated the gender and racial disparities in promotions in the Army. Because people were now forced to think, why am I? And it eliminated the biases that they had when they had to look at the facts. What case can I make why this person is not getting promotion? On the other hand, this eliminated the disparities as long as the general who put that in place was in command. When he left and they moved away from that procedure, they went right back. You have to be focused, and it can't rely on one leader and his success. The other thing I would want to talk about before I stop is that a comprehensive diversity program has to transform the organizational environment. The res indicators are important, but we need more than that. We need to completely create an organizational climate that is supportive, and we need to address not only recruitment issues, but support and retention issues. One of the things that is used, a term that is used in the research, is we need to create psychological safety as a key of the environments, the culture of our institutions. A psychologically safe environment is one where employees feel confident in expressing their ideas and beliefs without fear of negative consequences. We talked about employees going to board meetings and testifying to the board. I'm not sure if there will be no consequences for them. There are many contexts in which there will be consequences for doing that. So we need an environment of psychological safety where people are affirmed, and there are steps that have been identified of proactively we need to be eradicating intolerance and increasing minority representation and building the environment and the culture that is supportive of the kinds of initiatives we want. There's actually research that suggests, this is a Canadian study, that shows we can reduce incivility within workplaces. These were studies at 5 hospitals in Canada where they assessed at a unit level. They had units that they did this intervention with and control units, and they followed them over time. They used at the unit level structured exercises with facilitators to create and reduce the level of incivility among co-workers and among supervisors. And this process was successful. 6 months later, they had increased civility. There was greater trust in management, there was greater respect for co-workers, there was greater job satisfaction, and there was reduction in burnouts and absences from work. Dramatic results in a healthcare context in Canada. A year later, many of those improvements still existed a year later after the intervention had ended, except in one domain. Absences, they were no longer successful in reducing the absences a year later. The effect of absences had worn off, but all the other dimensions had continued. I also want to emphasize the importance of addressing implicit bias in the workplace. Many supervisors and managers with good intentions and a good heart are nonetheless, because of the implicit biases and stereotypes they have of BME people, may nonetheless be treating them unfairly. This is an example of a very carefully done study that found that Black people who are late receive more negative performance appraisals than white people who are late. And it's because the supervisor notices and zeroes in and documents the fact when they are late, and the same is not true for whites. So it highlights the importance of implicit bias training for employees. I also want to share you another recent study of STEM in science, technology, and engineering academics. These are professors at universities, documenting that even professors at universities are experiencing discrimination that is adversely affecting their work performance, their productivity, and their physical health. But what this study documented is that support from their supervisor reduces the negative effects of discrimination. So even those professors who experience discrimination, if a supervisor was supportive, was helpful to them, acted in ways that they were committed to their careers, the negative effects on their health and on their productivity were reduced. So the supervisor and training supervisors to be effective in providing support can make a difference. What will help you to be successful in the long term? If you look at the large literature on diversity, number one, leadership matters. It has to be clear from the leader of the organization that diversity is a priority and is central to the mission of the NHS Trust. Then all organizational levels of the organization have to be working together. You also need to identify and nurture a core of champions. Multiple people have to be delivering the message. People need to hear it from the leader, but they need to hear it from persons within and outside the organization. They need also, as Yvonne mentioned earlier, a steady drumbeat of information. We in our contemporary societies have a short memory, a short attention span. The fact we've had a successful launch today, you can't rely on that. You need to find ways in every 2 or 3 months, you find some way of bringing it to the attention of everyone so that people understand. We need financial support for diversity initiatives that don't just generically happen. Put our money where our mouth is, and we need to highlight interventions that are working. People are looking for success. We need to move from equality to equity. And I would argue equity is fairness, access to the same opportunities for all. We need to ensure equity before we can have equality. As Thomas Jefferson said, there's nothing so unfair as the equal treatment of equal people. But if we look at reality, the third person is down in a hole in reality. So this is where many BME folks are. We need to think of how we adjust reality and look to the future where we can even eliminate the fence or put a see-through fence, a wire fence that persons can see through, or actually create a fence where there are no barriers so that we are really leveling the playing field and making opportunities available for all. I leave you with the words of the great Sir Winston Churchill. It is no use saying we are doing our best. Our best is not enough. You have to succeed at doing what is necessary. Let us think of doing what is necessary. Thank you.
Wow.